Welcome to the VBAC Facts podcast. I'm Jen Kamel, VBAC Facts founder. And since 2007, our focus has been to provide accurate and objective information on VBAC and repeat cesarean to parents, professionals, policymakers in the court, so all decisions can be informed, ethical, and just. In our last episode, we talked quite a bit about ACOG's VBAC guidelines. But wait, there's more. Today, we continue that review and analysis of ACOG's guidelines, focusing in specifically on what they say in regards to external cephalic version, epidurals, VBAC in rural hospitals, who makes the ultimate decision, and more. Let's dive in. External cephalic version. Okay, let's talk about that. So that is when a baby is not in a head down position. And so the clinician can manually, externally turn that baby into a head down position. Some people think, oh, well, if you have a prior C-section, isn't that putting a lot of stress on the scar? Should we be offering an ECV? The reality is it is an option. And ACOG says, limited data suggests that external cephalic version with breech presentation is not a contraindication in women with a prior low transverse uterine incision who are candidates for external cephalic version and TOLAC. Moreover, the likelihood of successful external cephalic version has been reported to be similar in women with and without a prior cesarean delivery. We have a whole training on this topic within professional membership. Really key. When we talk about 3% of term pregnancies have babies who are breech, it's important to not only have the option of ECV available, but to have the option of clinicians who are trained in vaginal breech birth. That is one way we can reduce the primary cesarean rate as well as the repeat cesarean rate, is ensuring that people have access to this level of training with either an ECV or a vaginal breech trained provider. So analgesia, pain relief. We talked about that at the beginning, pretty much what ACOG says here. They say no evidence suggests that epidural analgesia is a causal risk factor for unsuccessful TOLAC. Therefore, epidural analgesia for labor may be used as a part of TOLAC, and adequate pain relief may encourage more women to choose TOLAC. However, epidural analgesia should not be considered necessary. Okay, I want all the providers who are like, I require my clients to have an epidural to listen up. In addition, effective regional analgesia should not be expected to mask signs or symptoms of uterine rupture, particularly because the most common sign of rupture is fetal heart rate tracings. Okay, so that's a repetition of what I said at the beginning. Fetal heart rate tracings are associated with about 80% of uterine ruptures, so they are the most consistent and reliant symptom. However, if you take our training within VBAC Facts professional membership on fetal monitoring during planned VBAC, you might be surprised at how often normal VBAC labors have abnormal, suspicious fetal heart rate tracings. And so that's where we get into the constellation of symptoms associated with uterine rupture, rather than just relying on fetal heart rate abnormalities. Okay, diagnosis of uterine rupture. So ACOG says most authorities recommend continuous electronic fetal monitoring. So most authorities recommend. There is no data to suggest that intrauterine pressure catheters or fetal scalp electrodes are superior to external forms of continuous monitoring. In addition, there is evidence that the use of intrauterine pressure catheters does not help in the diagnosis of uterine rupture. And that's because the loss of intrauterine pressure is actually a less reliable symptom of uterine rupture. If I recall correctly, one study cited about only 4% of uterine ruptures are associated with an intrauterine loss of pressure. So that's why those intrauterine pressure catheters do not help in the diagnosis of uterine rupture. Personnel familiar with the potential complications of TOLAC should be present to watch for fetal heart rate patterns that are associated with uterine rupture. Now note, they say personnel familiar with, so that can be the OB, that can be a family physician. It's not that the OB has to be present 24/7. And I know that might make some people say, wait, isn't that what ACOG says? That's actually not what they say. Uterine rupture often is sudden and may be catastrophic, and no accurate antenatal predictors of uterine rupture have been identified. In other words, no accurate predictors during labor have been identified. Acute signs and symptoms of uterine rupture are variable and may include fetal bradycardia, increased uterine contractions, vaginal bleeding, loss of fetal station, or new onset of intense uterine pain. And I would also add to that shoulder pain. It's referred pain when someone has significant internal bleeding in the abdominal cavity. They can experience shoulder pain. I think it really is important to talk about those types of symptoms that need to be self-reported with patients. So that way, if they do detect it, if they do experience it, they know what it is and they don't just ignore it like, oh, well, it's probably something else. You don't want people to blow stuff like that off. You want people to be knowledgeable about the symptoms and report it. However, the most common sign indicative of uterine rupture is fetal heart rate abnormality, which has been associated with up to 70% of cases of uterine rupture. Therefore, continuous fetal heart rate monitoring during TOLAC is recommended. There's a whole conversation about risks and benefits about that. We dive more deeply in that in our training on monitoring. Okay, here's another key statement. There is nothing unique about the delivery of the fetus or placenta during VBAC. Manual uterine exploration after VBAC and subsequent repair of asymptomatic scar dehiscence have not been shown to improve outcomes. So important. I hear about clinicians doing a manual exploration of the uterine cavity after delivery. That is not needed. Also, this repair of asymptomatic uterine dehiscences, it has not been shown to improve outcomes. So that's another thing that is not needed. And there's a whole conversation about uterine dehiscences that we could have here. I will just briefly say, I believe that most uterine dehiscences go completely unnoticed. And that's because uterine dehiscences are most frequently noted during a cesarean section. They can also be noted on an ultrasound. There are so many people who have vaginal deliveries who may have a uterine dehiscence, and it's never noted. It's important to share that just because someone has a prior uterine dehiscence, that may or may not have any influence on future pregnancies. And I have yet to see any research that indicates it does have a significant outcome. And again, I would really invite you to share research because when I make statements like that, look, I'm incredibly familiar with the VBAC research, but I have not read every single piece of evidence. So I welcome you, if you have seen research on this topic or other research that you would like me to see or feature, I invite you to go to vbacfacts.com/podcast and submit that information there. Because if there is research out there that has indicated that there is a substantial influence on a prior uterine dehiscence on a future pregnancy, I would love to read that. Okay, another question I get, I've had a prior uterine rupture, can I plan a VBAC? Okay, so first of all, I never tell individual people whether they can or should do one thing or another. I talk about what the research says, and then they can go from there. So here's what ACOG says. If the site of the ruptured scar is confined to the lower segment of the uterus, the rate of uterine rupture or dehiscence in labor is 6%. If the scar includes the upper segment of the uterus, the repeat rupture rate is reported to be as high as 32%, with the most recent report estimating the rate of reoccurrence to be 15%. Given these rates, it is recommended that women who have a previous uterine rupture give birth by repeat cesarean delivery before the onset of labor. In addition, because spontaneous labor is unpredictable and should occur before 39 weeks of gestation, the earliest recommended time for an elective cesarean delivery, similar to the history of a prior classical cesarean, the suggested timing of delivery between 36 weeks 0 days and 37 weeks 0 days of gestation should be considered, but can be individualized based on the clinical situation. So again, not a absolutely must do this at this time. This is again, even with a history of uterine rupture, a time where risks and benefits are discussed and a decision is made. Okay, in this next section, ACOG talks about how people should be counseled after a previous cesarean delivery. The discussion should consider individual characteristics that affect the likelihood of complications associated with TOLAC and elective repeat cesarean delivery, so that a woman can choose her intended route of delivery based on data that are most personally relevant. A VBAC calculator may be used to provide more specific information about the chance of VBAC, which can be used to further the process of shared decision-making. Okay, remember, The VBAC calculator, there is so much to consider there. Go to vbacfacts.com/calculator to read more. Whether you are someone planning a VBAC or someone who supports those planning VBACs, it's really important to understand what the VBAC calculator can say, what it does say, and the most effective way to communicate how it works and its conclusions to your patients, because it is not predictive. That is something that's so important to hear. It is not predictive. It tends to underpredict. And so really important to remember that. Another key point, counseling should address the resources available to support women electing TOLAC at their intended delivery site and whether such resources match those recommended for caring for women electing TOLAC. So this is a key topic because some facilities do not allow VBAC. They have policies called VBAC bans. And that's where they either they make people believe that they have no option but a repeat cesarean, or it might be a policy where we have clinicians working at that facility who say, look, our policy is not to allow VBAC, but no one can force you to have a C-section, and this is still your right. How that plays out can depend on so many factors. But one of the critical things for parents to understand when making the decision about where to labor is to understand the resources available. Is there 24/7 anesthesia? Is there not 24/7 anesthesia? What is the protocol in the event that when I go into labor, does the anesthesiologist come in, say when I am 6 centimeters? Or does the anesthesiologist stay at their home, which is 15 to 20 minutes away? What impact does that have on my outcome if I do have a suspected uterine rupture and I do require an emergency repeat cesarean? So what are the risks and benefits of laboring at this facility with this set of resources versus potentially driving 1, 2, 3 hours to a larger hospital that has a different set of resources, say 24/7 anesthesia? How some rural hospitals who offer VBAC manage this is by saying, look, the odds of someone having a fetal demise during a planned VBAC is 1 in 2,000. Let's say it's double at a facility like ours that does not have 24/7 anesthesia. So we're going to estimate the risk now is 1 in 1,000. And then they hand that over to the patient and they say, okay, so are you willing to accept a 1 in 1,000 risk of fetal demise if you labor at our facility without 24/7 anesthesia? Or would you rather drive 1, 2, 3 hours away to a larger facility, a tertiary level facility that has 24/7 anesthesia, and there you might have a 1 in 2,000 risk of fetal demise? That's how rural hospitals offer VBAC in a way that is ethical, in a way that is in line with ACOG guidelines, and in a way that ensures informed decision-making. And in some of these facilities, they have said, look, no one has chosen to go to that larger facility. Everyone has been willing to accept that higher risk, that double, remember, relative versus absolute risk, right? The absolute risk, 1 in 2,000, 1 in 1,000. Relative risk, the risk doubles, right? So it goes from 1 in 2,000 to 1 in 1,000. They have them make that decision. Different than shared decision-making, right? Because the decision itself is not shared. How can we have parents really own the outcome of their decisions if we claim the decision is shared? How can clinicians release their concern about legal liability if we are insisting to them that the decision is shared, right? Because then they feel like, oh, well, if the decision is shared, then I better be part of that decision because I want to protect myself legally. No, we don't do shared decision-making. We do informed decision-making, where the clinician offers objective risks and benefits, they offer their subjective recommendation, and then they support that informed decision. The only person who owns that decision is the laboring person, the laboring woman. They're the ones who own that decision. Available data confirm that TOLAC may be safely attempted in both university and community hospitals and in facilities with or without residency programs. And in fact, when I was updating the truth about VBAC for professionals, I added a 45-minute section about VBAC in rural hospitals, incorporating this new research on the topic. The bottom line is there are good outcomes. There are good outcomes, and there are rural hospitals right now who are offering VBAC and offering it safely and creating good outcomes and reducing the risk of a CREDA in their community. And let me tell you something, a CREDA in a community hospital, that is a dire situation, a surprise accreta. And surprise accretas absolutely happen because even with ultrasound and MRI, accretas can be missed prenatally and people could end up in community hospital with no blood bank. That's a very bad scenario. So when we're talking about the public health, when we're talking about all of us, when we're talking about the larger population, offering VBAC is a way to improve the public health by decreasing the rates of placenta previas, placenta accretas, hemorrhage. Obstetric hemorrhage is one of the top reasons for maternal deaths, and they are absolutely associated with C-sections. So if we want to reduce the maternal mortality rate in the U.S., one thing we can do is ensure that C-sections only occur when they are clinically needed or desired by the patient. Otherwise, people should be laboring. Ooh, another key phrase here. After counseling, the ultimate decision to undergo TOLAC or repeat cesarean delivery should be made by the patient in consultation with her obstetrician or other obstetric care provider. Key. This is such an important section. What resources are recommended for obstetric or other obstetric care providers and facilities offering a trial of labor after previous cesarean delivery? So they say trial of labor after previous cesarean delivery should be attempted at facilities capable of performing emergency deliveries. Now, immediately, a lot of people might say, oh, well, that leaves my hospital out, right? Because we aren't capable of performing emergency deliveries. But let's look at what that actually means. The American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine's jointly developed obstetric care consensus documents, Levels of Maternal Care, which introduced uniform designation for levels of maternal care, recommends that women attempting TOLAC should be cared for in a, what do you think it is? Level 1 center, i.e., one that can provide basic care or higher. A Level 1 center. Level 1 facilities must have the ability to begin emergency cesarean delivery within a time interval that best considers maternal and fetal risks and benefits with the provision of emergency care. The American College of Obstetricians and Gynecologists and international guidelines have recommended that resources for emergency cesarean delivery be immediately available. However, some have argued that this stipulation and the difficulty in providing required resources limit women's access to TOLAC, especially in smaller centers with lower delivery volumes. This may be particularly true in rural areas where traveling to larger centers is difficult. Yes. So when you hear that ACOG says community hospitals or rural hospitals are not, quote, allowed to offer VBAC, the response is that is inaccurate. ACOG does not say that. What ACOG says here is any hospital, any level 1 hospital that has an L&D unit, or even that is capable of performing emergency delivery, should be offering VBAC. That's what ACOG says here. And it is astonishing to me because we're recording now in 2024. These guidelines were published in 2019. This was an interim update from the 2017 guidelines, which made the exact same statement. So this is not new information. And yet there are still so many hospitals across the U.S. that ban VBAC. And I really urge you, if you work at a facility like that, share this podcast. Share what ACOG says, because there is an opportunity for improvement here for you to provide evidence-based ethical care. And if you're interested in increasing VBAC access and outcomes while decreasing liability risk, I do have a training that I can offer. I can come out to your facility. I can also do a Zoom training for your clinicians at your hospital or even the clinicians in your area. You can group together and we can have a big group training. Wouldn't it be amazing if the hospitals in your area were all on the same page about what the evidence says, what ACOG says, and how to provide VBAC ethically and safely while also decreasing their litigation risk, reach out to me. Go to vbacfacts.com/speaking. You can schedule a time to talk with me, and let's chat about improving outcomes in your area. Okay, back to ACOG's guidelines. They say restricting access was not the intention of this recommendation, but much of the data concerning the safety of TOLAC is from centers capable of performing a timely emergency cesarean delivery. Although there is reason to think that more rapid availability of cesarean delivery may provide a small incremental benefit in safety, comparative data examining in detail the effect of alternate systems and response times are not available. So again, this is an area where we have limited data. And like I said, I did just update the Truth About VBAC to Professionals. It has a 45-minute section on rural VBAC. It's going to blow your mind. And I can't wait for you to take it and for you to let me know what you think and for you to let me know how it changed how you view community VBAC. What do you now see as possible in your community? I mean, that's the power of this information, is for us to be able to align our practice with the actual evidence. It's really exciting. Okay, so because of the risks associated with TOLAC and because uterine rupture and other complications may be unpredictable, ACOG recommends that TOLAC be attempted in facilities that can provide cesarean delivery for situations that are immediate threats to the life of the woman or fetus. When resources for emergency cesarean delivery are not available, ACOG recommends that obstetricians and/or obstetric care providers and patients considering TOLAC discuss the hospital's resources and availability of obstetric, pediatric, anesthesiology, and operating room staff. That's exactly what I talked about when we talked about counseling, right? All of that is important. That's all part of the informed consent process, right? I think it's also important to consider that there are people laboring at these facilities without a prior cesarean who don't even think about the fact that 24/7 anesthesia isn't available. The reality is, if hospitals are attending labors, if they are attending labors of someone who doesn't have a prior cesarean, those same emergency protocols that would be deployed in the event that that person without a prior cesarean required an emergency cesarean, those same protocols are employed in the event of a uterine rupture. So it's not like these hospitals don't know how to respond to emergencies. They do. They have those protocols in place. These recommendations are concordant with those of other professional societies. The decision to offer and pursue TOLAC in a setting in which the option of emergency cesarean delivery is limited should be carefully considered by patients and their obstetricians or other obstetric care providers. In such situations, the best alternative may be to refer patients to a facility with available resources. Now, as we discussed, facilities with available resources may not necessarily offer VBAC. We don't have great national data. In 2013, the International Cesarean Awareness Network called every single labor and delivery unit throughout the U.S. and asked them, do you attend VBAC? Do you have a VBAC ban? And they plugged that into a database. And it is an amazing collection of data, which I still cite. But that data is 11 years old. So we have other research from Dr. Mary Barger, a certified nurse midwife here in Southern California. She conducted a study where they called all the labor and delivery units in the state of California. This is relevant to the rest of the country because California, 1 in 8 U.S. births occur here. I'm in California. And California also has very large urban areas, but we also have a lot of rural areas. So what is happening in California, it may be an indication of what's happening nationwide. Dr. Mary Barger's 2013 study looked at all the hospitals in California that have 24/7 anesthesia. I want you to guess how many of them offered VBAC. 79%. So that means 29% do not offer VBAC. So of all the hospitals in the state of California that have 24/7 anesthesia, 29% don't offer VBAC. So to go back to what ACOG says, just because there might be a hospital in the area who has 24/7 anesthesia, that doesn't mean they offer VBAC. So that's a really critical aspect that I think is missing from ACOG's VBAC guidelines, is the acknowledgement that offering VBAC, that hospital VBAC policy, is not necessarily determined by staffing and resources. It's really determined by motivation. I have found that the only unifying factor among hospitals that offer VBAC is the motivation to do so. Because when we look at hospitals who offer VBAC, the staffing and resources can vary wildly. And we see that in particular when we look at hospitals that offer rural VBAC and do so safely. Again, check out The Truth About VBAC for Professionals for more on that. Okay, let's continue on. The decision to offer and pursue TOLAC in a setting in which the option of emergency cesarean delivery is limited should be carefully considered by patients and their obstetricians or other obstetric care providers. Another alternative is to create regional centers where patients interested in TOLAC can be readily referred and needed resources can be more efficiently and economically organized. Love this idea. Love this idea. And this is a great idea to be working towards in the future. But I think it's also really important to remember that there are people who are pregnant after a cesarean today who are seeking VBAC. So in conjunction with these future plans, we need to remember, how are we going to serve these people who are pregnant after a cesarean today and need access to care? Obstetricians and other obstetric care providers and insurance carriers should do all they can to facilitate transfer of care or co-management in support of a desired TOLAC, and these procedures should be initiated early in the course of antenatal care. However, in areas with few deliveries and long distances between delivery sites, organizing transfers or accessing referral centers may be untenable. And that is the reality for hundreds of thousands, for millions of Americans every year, is trying to access healthcare in our healthcare deserts and in our maternal healthcare deserts in particular. And this is the incredible power that rural facilities who do offer VBAC right now, that incredible service and hole that they are able to plug. Because there are people who need access to care who are unable to receive it. And when we have things like VBAC bans, even further, we have these maternal healthcare deserts, right? And then we have VBAC healthcare deserts, which are even more dry, even more wide, even more far-reaching. We have about 1 million C-sections every single year in the US, and many of those people go on and get pregnant again. So when we're talking about public health and when we're talking about addressing public health, reducing maternal morbidity and mortality, we need to not only reduce those primary cesareans and ensure only people who want or need C-sections are having them, but we also have to ensure that VBAC is a viable option in every single facility that offers L&D. By doing that, by increasing VBAC access, we can experience a reduced rate of maternal morbidity and mortality. And that is really our ethical obligation. Consistent with the principle of respect for patient autonomy, patients should be allowed to accept increased levels of risk. However, patients should be clearly informed of the potential increases in risk and management alternatives. And key, yes, ACOG, yes, this is so key. And how do we have these conversations where we talk frankly and transparently about risk, about fetal demise in the setting of uterine rupture, about bad outcomes, about risks and benefits, about future pregnancies, about all of that? How do we do that transparently, honestly, and with integrity, and without generating excess fear? It's that second part that I think clinicians have this is what I have heard. I have heard clinicians tell me this can be a challenge for them, right? Because they want to be honest, but they don't want to generate fear. We talk a whole lot about this within VBAC Facts professional membership. It is absolutely possible and it can be done. That is the power of informed consent, right? Because we don't ever want someone to experience a uterine rupture and say, I had no idea this could happen to me. Just like we don't want someone to experience a placenta accreta and say, I had no idea this could happen to me. And I have to tell you, of the surveys that I have conducted among people who have experienced accreta, over 50% heard the word accreta for the first time upon their own diagnosis. No one had ever mentioned it to them. And these are parents and these are women who had 2, 3, 4 prior cesareans. And with every cesarean, their clinician is letting them know, oh yes, this is totally the safest thing. This is the safest option. Safest is subjective. Safest is a judgment that the person makes, the woman makes, after understanding the risks and benefits. Because as we saw from ACOG, 2 people can look at the same information and make totally different decisions based on what they perceive as safest. That goes back to that whole conversation about family planning to talk about how many children do you plan to have? We don't ever want someone to be surprised. We don't want them to be surprised about staffing or about uterine rupture or about placenta accreta. All of these things should be well known within the decision-making process because that's what informed decision-making means. So elevation of a patient's individual likelihood of VBAC and risk of uterine rupture are central to these considerations. Yes. Some conversations and decisions should be documented. Yes. And include reference to anticipated risks and site-specific resources. Yes, yes, yes. Referral may be appropriate if, after discussion, obstetricians or other obstetric care providers find themselves in disagreement with the choice the patient has made. Okay, that's a little sticky, right? That's a little sticky and gets into who ultimately owns that decision. And I think, again, we need to go back to this concept of rights and responsibilities. Who makes the decision? Who owns the decision? Because if the clinicians are there as a lifeguard, they don't own the decision, right? They are being very clear. For example, someone who's pregnant after 3 cesareans and wants to labor. Honest assessment is to say, we don't have solid evidence on the level of risk of uterine rupture after 3 cesareans, laboring after 3 cesareans. We don't. Side note, if you heard that there is solid evidence, there's not. Go to VBACFacts.com/VBA3C to read more. We don't have solid evidence on the risk of uterine rupture, laboring after 3 cesareans. This is an area of unknown risk. It is your right to make this decision, and we will do everything we can to generate a good outcome in the event that you are a statistic and you have a uterine rupture. However, we cannot guarantee an outcome. Here are resources. Here is the plan if you have a uterine rupture. These are the things that we're going to do to generate a good outcome. But no one can guarantee you a good outcome. And especially when you, the patient, makes a choice that is associated with higher or unknown risk. You own the responsibility for that decision and for the outcome. In doing so, that releases the provider from feeling like, I am responsible for this decision. Because the reality is the provider is not a deity. They cannot guarantee an outcome, and they cannot see into the future. So to expect them to be able to say, you're going to be perfectly fine, no one can say that. And it's so reassuring as a patient to hear that. But if someone says that to you, there's always risks and benefits. So understand what the risks and benefits are, make your informed decision, and parent, own that decision. And provider, that decision is not your responsibility. So that's how we get around this whole, we're going to have to transfer you out. If the clinician is able to separate themselves from the decision and see themselves as a lifeguard rather than a deity who can see into the future or guarantee an outcome, we have a completely different dynamic, right? Okay. Oh, the other thing with a referral may not even be an option. There may not be a facility in the area who not only supports VBAC, but will take your patient and accepts your patient's insurance. So it's not enough that a hospital accepts VBAC. It's that whole insurance overlay as well, right? So we have to consider the bigger picture. That's why if it's possible to maintain care, of course, if there is a situation where they need to be referred out to a maternal fetal specialist, that's a different story, right? But if we're just talking about a disagreement about the birth, again, clinicians, you are the lifeguard. Patient is the person who makes the ultimate decision and holds the responsibility for that outcome. Okay, ACOG says, moreover, because of the unpredictability of complications regarding emergency medical care, home birth is contraindicated in women undergoing TOLAC. Okay, so let's just briefly talk about this. We've already talked about maternal healthcare deserts. We've already talked about the incidence of VBAC bans. We've talked about the difficulty that people have trying to access evidence-based care. And in the midst of that, many parents face this decision. I can birth in a hospital in my community and have a repeat cesarean that I do not want and I do not feel like I need. I can travel, sometimes very long distances, to another facility that may support VBAC. I can have a home or birth center VBAC with a midwife in my community, or I can plan an unassisted birth. All of these options come with risks and benefits. And the reality is, what we should all be doing is working together to ensure the best outcome for everyone. And so rather than saying that home birth is contraindicated, I would urge ACOG to set the tone of how can we improve outcomes together? How can we improve access to VBAC in all facilities? How can we improve collaboration with midwives so those home birth transfers are quick and smooth? So when someone transfers in, they're not worried about judgment or retribution, where the midwife is able to call into the hospital and say, hey, this is the scenario, we're headed in, have the OR ready, and they arrive. There is no backbiting, there is no debating, there is no judgment. The sole focus and purpose of that interaction is to address the clinical situation. That will improve outcomes. It is the fear over abuse that can delay transfer in a home birth situation. It is really important for us to all realize that we are all on the same team and we are all trying to generate the best outcome for everyone. And by working together through collaboration, that's how we make that happen. And by looking deeply into why people choose home birth, they're seeking midwifery care. There was just news of another midwifery practice being closed down in the Chicago area this past week. People are seeking midwifery care. That's what they want. And in many communities, the only place they can access that is community birth. Community birth meaning home and birth center birth. So there are many reasons why people choose home birth, out of hospital birth, community birth. Access to midwifery care is one of those reasons. Access to VBAC, period, in their community is one of those reasons. So I think it's a little short-sighted to just say a prior cesarean is a contraindication to home birth without looking at the larger political realities of this is how, for many people, the only way that they can access either midwifery care or VBAC care in their community. However, none of the principles, options, or processes outlined here should be used by centers, obstetricians, or other obstetric care providers or insurers to avoid appropriate efforts to provide the recommended resources to make TOLAC available and safe as possible for those who choose this option. Here. That is a critical aspect, right? In settings where the resources needed for emergency delivery are not immediately available, the process for gathering needed staff when emergencies arise should be clear, and all centers should have a plan for managing uterine ruptures. Exactly. Drills and other simulations may be useful in preparing for these emergencies. Yes. Okay. Another key point. Listen. Respect for patient autonomy also dictates that even if a center does not offer TOLAC, such a policy cannot be used to force women to have a cesarean delivery or to deny care to women in labor who decline to have a repeat cesarean delivery. Key, right? So if someone says, hey, I want a VBAC, and I know your facility has a VBAC ban, those hospital policies cannot be used to force women to have a cesarean delivery or to deny care. So I think this is so important, and this is why, again, this episode is so important for parents, clinicians, and professionals, because we hear directly from ACOG, even though you have a VBAC ban, that doesn't mean someone cannot have a VBAC. That does not mean that they are required to have a C-section. That does not mean that that policy now supersedes everything we know about the law and people's rights to make informed decisions and people's rights to make their own decisions about their bodies, especially when it comes to surgery. Okay? So a policy is a policy, and that does not supersede the law. And ACOG is very clear here about what that policy can and cannot mean. You can have your policy say whatever you want, but at the end of the day, it cannot prevent people from planning to VBAC at your facility. That is not only unethical, but it's outside of ACOG's guidelines. And I would argue it absolutely violates the ethical principles of informed consent and subjects people to that 5 times greater risk of maternal mortality. And how can we argue that that is the right thing when you are telling someone you have no option here but to have an elective repeat cesarean that increases your risk of maternal mortality by 5 times? That is unethical. When conflicts arise between patient wishes and the obstetrician or other obstetric care provider or facility policy or both, careful explanation and, if appropriate, transfer of care to facilities supporting TOLAC should be used. Now, again, that's assuming that we have other facilities within the community who support VBAC and take their insurance and will accept transfer of care at whatever point in pregnancy they are. Coercion is not acceptable. Okay, we are now to like the last few sentences. I think that's like the third to last sentence in ACOG's VBAC guidelines. Coercion is not acceptable. Why does ACOG say this? ACOG says this because they know coercion happens. Because at the 2010 National Institutes of Health VBAC conference, we had numerous stories shared. And I think ACOG, maybe that was the time that they finally heard and really embodied what was happening out there. And what was happening is that people were coming up against VBAC bans and were told, you have no choice here but a repeat cesarean. And that is false. But that's what they were told. They were told that a hospital policy supersedes their right to make their own medical decisions. That is false. But that's what people were told. So that's why ACOG includes this in here. And in fact, I believe it was their 2010 ACOG guidelines that came out shortly. It was within 3 months of the National Institutes of Health VBAC conference that they first introduced this word coercion in their guidelines. That's really important for everyone to realize is what power hospital VBAC policies have and who owns the ultimate decision. What power they have, people can have whatever policies they want, but at the end of the day, everyone has the right to decline a cesarean, regardless of what policy states. Because relocation after the onset of labor is generally not appropriate in patients with a prior cesarean scar, who are thereby at risk of uterine rupture. Okay, this is also a factor to remember when people are driving 3 hours to a higher level of care, right? If a community hospital says, we don't offer VBAC, you have to go 3 hours away. Do we want people in labor driving 3 hours on rural roads and giving birth on the side of the road? Also, say the hospital is 3 hours away and they say, okay, so at 37 weeks, I'll just move closer to the hospital until I go into labor. That's great for the people who have the resources to be able to do that. Most people do not. So this notion of just go to another hospital is a lot more complicated. Are you going during labor? Are you going before labor? So lots of things to consider. Okay, back to what ACOG says. Who are thereby at risk of uterine rupture. Transfer of care to facilitate TOLAC, as noted previously, is best effected during the course of antenatal care. This timing places a responsibility on patients and obstetricians and other obstetric care providers to begin relevant conversations early in the course of prenatal care. Conclusion. Okay, then we go into the summary of recommendations and conclusions, which I'm not going to read all of them here for you, but I do want to highlight this particular recommendation. As I read it, I want you to think, what level of evidence is associated with this recommendation? Okay, level A, again, is good and consistent scientific evidence. Level B is limited or inconsistent scientific evidence. And level C is based primarily on consensus and expert opinion. Okay, so I'm going to read this recommendation to you from ACOG's 2019 VBAC guidelines, and I want you to think, what level of evidence supports this statement? Trial of labor after previous cesarean delivery should be attempted at facilities capable of performing emergency deliveries. What do you think, A, B, or C? It's C. Okay. Women attempting TOLAC should be cared for in a level 1 center, i.e., one that can provide basic care or higher. That's also level C. Because of the unpredictability of complications requiring emergency medical care, home birth is contraindicated for women undergoing TOLAC. That is also level C. Most women with one previous cesarean delivery with a low transverse incision are candidates for and should be counseled about and offered TOLAC. That's level A. So, I'd really love to know, what was the most surprising thing that you learned from ACOG's VBAC guidelines today? Leave a comment. You can go to vbacfacts.com/podcast. Let me know there. I would love to read your feedback on the air, because I know that when I offer trainings, people are so often surprised about what ACOG says and what they don't say, and what the conventional wisdom says that ACOG says versus what ACOG actually says. So let me know what you really enjoyed. And until next time, I'm Jen Kamel from VBAC Facts. It has been a pleasure being with you today. And don't forget what we're about. Since 2007, our focus has been to share objective and accurate information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court, so all decisions can be informed, ethical, and just. Thanks so much for being with us today, and I'll see you next time. Take care.